All right. Well, good afternoon, everybody, and thank you so much for joining us today. My name is Tyson Campbell. I'm a certified athletic therapist as well as a member of the Athletic Therapy Ontario group. Thank you so much for joining us today for a virtual Lunch and Learn session as we kick off Concussion Week 2023. And just before we get started, we would like to acknowledge that we are on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, the meeting place of Toronto is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work and learn on this territory. In this land acknowledgement, we recognize and respect Indigenous peoples as traditional stewards of this land and the enduring relationship that exists between Indigenous peoples and their traditional territories. We recognize the importance of reflecting on what occurred in the past as an important step to reconciliation with our Indigenous communities and other communities that have experienced hardship as part of our colonial past. We also recognize the challenges and discrimination that can exist in the healthcare system towards persons with Indigenous background. As system planners, it is our responsibility to identify and implement mechanisms to provide equitable and culturally sensitive care. The Athletic Therapy Ontario group would like to give a warm welcome to UNH and the Kite Research Institute and all the partners that they bring with us to this session today. So we do have a tight schedule for our agenda today, but we will be separating this into two segments. The first segment will be presented by UNH, and the second segment will be presented by the Athletic Therapy Ontario group. Following, we will have a Q&A session for those who may have questions regarding the material being presented today. We do have a terrific lineup of concussion educators, researchers, and policymakers today, including Judith Gargaro, Dr. Sean Marshall, Drew Liskowski, as well as myself. So the point of today's session is to review caring for a person with post-traumatic brain injury and the important role that the athletic therapist provides. The first segment is going to be divided into three parts. And at this point in time, I'm going to hand things over to Judy to talk about this with us.
Thanks, Tyson, and I'm happy to be here today. So I'm the manager of the Neurotrauma Care Pathways Strategy. So I'm going to introduce you to that a little bit and introduce you to the Canadian Clinical Practice TBI guidelines. These are for moderate to severe brain injury. I'm not going to talk too much about that. And then I'm going to pass things over to Dr. Sean Marshall, who's going to talk more in detail about the living concussion guidelines. So our objectives are as follows. And again, I'm going to just gloss over my section just because I want to make sure to have enough time to get to the meat of the session, which are the concussion guidelines and the case examples. So the Neurotrauma Care Pathways Project is funded by the Ministry of Health and a grant to UHN, and we've been charged with developing, implementing, and evaluating evidence-based ideal care pathways for concussion, moderate to severe TBI, and traumatic spinal cord injury. And over 200 key partners have been engaged across the province, particularly focusing on engaging persons with lived experience. And so when I'm talking about an ideal care pathway, we've developed the short version is what you see on the screen. So again, those 4 stages of care aren't a surprise to anybody. And we're really focusing in on the role for team-based primary care and also the idea of taking into account people's environmental and personal factors. And underneath each of these main stages of care, there are building blocks of care, which are linked to existing evidence-based clinical practice guidelines. And so these care pathways are organized, as I said, with these building blocks of care, and the clinical practice guidelines come off each one of these building blocks. And ideally, if the gaps between the current and the ideal practices can be eliminated through the implementation of each of these building blocks and the companion quality indicators. So again, a lot of detail on these slides, but you will have them afterwards that you can look at them in more detail. So we developed companion quality indicators with clear definitions and technical specs. And we also made comments about the status and feasibility of these. And so some building blocks contain multiple quality indicators, but we've tried so that each block has a quality indicator. And our focus is really on the core set of 22 indicators that we're working on getting implemented across the system. And this will give us feedback on how well the system is doing against the ideal care pathway. So as I mentioned, living clinical practice guidelines are linked to each building block of care. So there's underneath all of these pathways of care, there's the Canadian Clinical Practice Guideline for moderate to severe TBI. So I'll just briefly touch on that. There's the Living Concussion Guidelines, with which Dr. Sean Marshall is the lead of that. There's also a Pediatric Concussion Guideline, and then CANSCIP, which is the Canadian Spinal Cord Injury Guidelines. So these are all living guidelines that feed into each building block of care in the ideal pathway. So this is just an overview of the moderate to severe clinical practice guideline. You can see there's lots of different chapters that are there with specific clinical advice. So if you were to click on any one of those lettered areas, you would get an expansion onto the key components of rehabilitation. So there'll be a rationale for why this section is important. There'll be system implications, the key indicators, tools and resources that go with that, and then a summary of evidence. And this is an example of the summary of evidence, which we do because a lot of folks find it helpful when they're advocating for services for their clients to be able to reference the summary of evidence. And we've also continually add new sections as more information comes online. So this year we've added a telehealth section and also a section on intimacy and sexuality. So what I'm going to do now is I'm going to throw it over to Dr. Sean Marshall, and he's going to speak about the Living Concussion Guidelines.
Great. Thanks, Judy. I don't think I have camera available, so on technology here. So in my office, and I'm not even sure that I'm able to advance my slides, but to the slides, but I'll probably just ask for next slide as you go along. So just introducing, so they're calling them the Living Concussion Guidelines. I think I'll give you some background on that. So I'm a specialist in rehabilitation medicine. We have had the guidelines in existence since 2008. And I'm going to guess as an athletic therapist, this is a lot of what you guys see. So what we're going to talk to is kind of the transition to the guidelines. As you can see, how you can use them, the concussionontario.org, or you can see the QR code there. And if we go to next slide. So, I don't think I'm talking to athletic therapists. So concussions can result in disabling symptoms, and an unfortunate minority also experience prolonged symptoms. And that's, kind of two things what we're trying to do. We're trying to have early recognition and diagnosis of the concussion, so that proper treatments can be carried out, and that's forever changing. I'm sure that you've had new information about that, even in the last number of years, and for those of you who've been around being athletic therapists for a while. And clinicians and patients require up-to-date guidance on diagnosis and treatment. Interestingly, not a lot in a lot of medical courses and nursing courses, this isn't as emphasized, given frankly, the prevalence of concussion injury, which is pretty significant. Many people in the population have them, like we're upwards of probably 1,200 per 100,000. That's a lot of people that's the incidence per year, if we're looking at all levels of concussion. Research is published rapidly, and there's a lot. I don't think I need to tell you that there's been a lot more into this in this topic over the last number of years, looking for, first of all, how to diagnose concussion, and secondly, how to manage it, how to prevent people from having prolonged symptoms and even managing those prolonged symptoms. So next slide, please. So, our methods. So I just wanted to give you, why is it important for you to say the methods? And I usually say this because with a guideline, you have to have confidence in the information you're using, because there's many, many guidelines out there and you want them to be practical. So a systematic review is being conducted to provide supporting evidence. Our guidelines go back indefinitely, but the more recent one has been to 2017 and future. Searches are conducted approximately every 6 months. That's what makes this a living guideline. I'm going to show you some a slide, the next slide, that will say that listen, there's tons of information and it's actually ever increasing, so it becomes almost unmanageable. And you want your guidelines to be up to date. Frankly, historically, we would update the guidelines every 4 or 5 years. Well, if things are changing more rapidly than that, then having a guideline that's updated every 4 or 5 years isn't necessarily helpful. So we're looking at English peer-reviewed studies, and we have over 40 concussion experts from across North America who help with this. And of course, we're always looking for more experts to join us. So if any of you are interested, I'm happy to hear about this, because looking at more people, more perspectives, to look at this ever increasing literature. Next slide, please. So again, this is just showing to you the process. So, when we do a search, you guys are familiar with this. It's rather mundane, but can you imagine going through 26,000? My team goes through this, which I'm very much appreciative of, because I have done this in the past, but it wasn't to this volume. And we had 1,015 retained documents, means that we did the full screening of these documents and extracted them to help inform our guidelines to our expert panels. Next slide, please. This is just showing, so one, a lot of research goes in, a lot of background work goes into this. This is just showing you our guidelines used. This is actually only since February 2022, just showing you kind of over 1 year. So we have about 16,000 people per year. Now we're targeting healthcare providers. So in my mind, this is pretty positive in that we are targeting people who will actually, health professionals who are treating many patients exponentially above and beyond this. So I think our guidelines have had good review. They've come off as high quality when people have independently reviewed them. And I'm saying this to hopefully convince you that they're useful and hopefully have meaning. And if you have ideas about how they can be better improved, we're always open to hearing that. Next slide, please. So this is the new website that we have. We've done a reorganization of this. As we all know, websites change. These are the 12 sections that we have here currently. We expect to expand this, to look at things. We're going to actually look at, for instance, predictors for diagnosis of concussion, so biomarkers, and we're really looking at kind of concussion in older persons. So we're expanding this, and concussion in females, because we know that that they can have differences in how they present and respond to concussion. So we are working on that in the background. These headaches would have guideline recommendations, and an important element is resources. So we can go next slide, please. So with the concussion, in fact, we're talking here about diagnosis would be one of the sections we use. We try and give background, relevant background to the expert provider who's using this healthcare for the healthcare clinician. And we have access to articles and resources that we have available. And this would be kind of how the website looks like when you come to it. Next slide, please. So again, we've grouped it and we've arranged it. And why am I showing this to you? You're thinking, because I want you to have a sense of what to expect when you see it. The key thing is transparency, and key thing is access to information. So here we've organized under three elements. So recommendations are the specific recommendations the expert panel has come up with. The third title there, summary of evidence, is the evidence that we've used for the experts to be influenced in making their guideline recommendations. So whether it's a level A, B, or C guideline recommendation, this is the evidence that's been used to inform that decision with the expert panel. And then I think an important one is tools and resources. And of course, as you can imagine, I think the sport concussion guidelines have done a very good job of this. What are the resources that we use? So for instance, the SCAT or the SCOAT with the new Amsterdam conference and some of the new resources, or SCAT 6 and SCOAT 6. These tools are things that we try and make available to people to have freely and ready at hand. For things like headache management, algorithms, and these sorts of things, it will help you in managing some of the symptoms that you're commonly incurring with your patients. And then for assessment, under the heading of diagnosis, for instance, very relevant to athletic trainers, what are some of the tools that can be used for screening and moving on? Next slide, please. So recommendations, you can see here. So this is just an example of a recommendation, which I'm trying to do for the screenshot. So suspected concussion should be recognized as soon as possible and referred to a physician, nurse practitioner for diagnosis confirmation. So again, this is where we work together as an athletic therapist. I think a lot of you are seeing patients and players on the field, live, first to contact, and then this recommendation is saying refer to physician, nurse practitioner for diagnosis confirmation. And then we're putting in context, while other experts beyond physician, nurse practitioner may effectively recognize concussion, and in essence, probably diagnose concussion, we do recommend referrals should be made to physician, nurse practitioner who can access healthcare resources and infrastructure needed to fully assess and care for a patient following concussion. The way I look at this is, in my practice, I'm a rehabilitation physician. Most of the patients I see each and every day are my inpatients who have moderate severe brain injuries, And this is really looking at who needs to be evaluated further. So for instance, I just saw a patient who, was in a consult literally before this appointment, 26-year-old, knocked over by an e-bike. And in essence, while her primary presenting symptom was headache, walking, talking, went home and went home that night. The next day she showed up, her headaches were really bad. She has a she's admitted to hospital with a multi-compartmental bleed based on CT scan. And again, probably would have been concussion-based examinations or everything, but there's certain indicators that would say we need further investigation and moving ahead, and that's therefore this recommendation, just as an example. But again, all of us working together. Next slide, please. So tools and resources. So these are some of the tools that can be used. Obviously, I'm talking to athletic therapists, so I'm going to, I normally plug, and when you're looking at the sports section, the SCAT6 or the SCOT6, but these are tools that can be used, within, different settings. So the Canadian CT head rules, I think it could be a great example of, why did that 26-year-old get a CT of her head if she actually, was presenting to the emergency room? And there were certain criteria that she made that allowed the CT head rule to be carried out. So again, things that are available freely at hand for you to use and give some direction for managing care. Next slide, please. Okay, and then tools, and resources, summary of the evidence. This is going in the heading of summary of the evidence. This is to show you that if you did want to look up the original articles or see what we're using to make these decisions, that those references are available and where you can get them accessible. Next slide, please. So diagnosis, I do want to go into this just so you're aware. This does relate to mild traumatic brain injury and concussion. There has been a change in the definition by the American Congress of Rehabilitation Medicine. This is on our website. So diagnosing concussion is the first critical step in successful management leading to improved outcomes and prevention of injury. So the guidelines, our guidelines have updated this. Noah Silverberg and his group in the American Congress of Rehab Medicine have come up with this new definition, which actually is being updated from the 1990s, if you can believe it. And I can tell you back in the 1990s, not much attention was paid to concussion at that time. Next slide, please. And what we're trying to see here is these are the diagnostic criteria for the AACRM diagnostic criteria for concussion. So, and they're helpful. And it does look a bit complicated because you're seeing there. And I'm going to be honest, in probably athletic therapists and sports, it's probably a bit more clear. But you want to do a couple things. You want to make sure you have the correct diagnosis. To one, make sure that people who do have a concussion get recognized and identified. And you also want to identify those persons who don't have a concussion. Understanding that many people often say they have had a concussion or believe they had a concussion, and it's probably suggestive that they don't. So criterion one, mechanism of injury, is plausible. And interestingly, as athletic therapists, there may be conditions where someone says, oh, I think I've had a concussion. But even if you look at the mechanism of injury, it may not be plausible they've had a concussion. And then we go on to criteria two, looking at clinical signs. So again, clinical signs would be, for instance, as an athletic therapist, very important to diagnosis. You saw the patient actually be forgetful outside the field. You applied a scat and they're confused and dazed. That's a sign that there's something wrong. Second sign is imbalance. So in fact, they have impaired balance. That would be a sign. Again, good evidence that this person has had, in fact, a concussion. You may not think of this, but you guys are the first to see these individuals who are saying, yes, they're more likely to have had a concussion or not. Acute symptoms, so onset of headache, confusion, sleep impairment, these sorts of things, vision difficulties, balance difficulties, and then clinical examination and laboratory findings. So again, the acute, clinical signs are seen, but then when we do a laboratory investigation, there might be biomarkers might fall in this in the future, and clinical examination. So we actually have abnormalities on exam. Criterion 5 is very simple. If you have image abnormalities on CT or MRI, conventional CT or MRI of the brain, then actually you've got a mild traumatic brain injury, which is different than concussion. With this diagnostic criteria, I should highlight that they're being used synonymously for concussion and mild traumatic brain injury as long as no evidence of intracranial injury. All right, so the mild qualifier is not used if any of the severity indicators listed below are present. So loss of consciousness duration greater than 30 minutes, that equals a moderate severity brain injury. And if they actually have neuroimaging abnormalities, post-traumatic amnesia greater than 24 hours, or after 30 minutes, a Glasgow Coma Scale score of less than 13. These are indicators of moderate to severe brain injury, of course, as distinguishers. Next slide. And again, these are kind of what I was just referring to in the last, so acute symptoms, clinical signs. The clinical signs are loss of consciousness, alteration in mental status that we described, partial amnesia, and other neurological signs such as balance or loss of balance. And the acute symptoms, confused or dazed, headache, nausea, physical symptoms, cognitive symptoms, and emotional symptoms. And then laboratory findings. So documented cognitive impairment. Typically as athletic therapists, although often, we work with older person may not be, but younger people, for instance, should have normal cognition. They should have normal balance, normal more ocular motor, and then even looking at elevated blood biomarkers. So for instance, there's still some valid indicators of people who have blood tests that suggest they've had a more serious brain injury. So these are the lab findings or the in-clinic findings that would suggest that there is evidence of a concussion. This is important on two fronts. One, concussions often unrecognized, often complicated. In sport, maybe a little bit more clear, but in other circumstances, such as motor vehicle collisions, falls, not as always clear because there might be associated orthopedic trauma. And the second reason is that we also don't want people being treated for concussion when they don't have one. And we want, and there's also, which should be also clarified, is that they, in this definition, there is the, inconfirmed, not able to fully say they've had a concussion or not, and that is the criteria. We still treat them, but we may not be able to have confirmed diagnosis of concussion. Next slide, please. So the sports section, I just want to highlight that we are in the pleasant process of shortly updating our guidelines. There have been some changes from the Amsterdam conference in October of 2022. As you can see here, the consensus statement has been drafted and published in the British Journal of Sports Medicine. Our experts are on our concussion committee. A number of them did attend this conference, and we are currently updating our sports section to align with this because we don't want to have mixed messaging. And for the pediatric concussion guideline, for the adult concussion guideline, and for Parachute Canada, we are working very hard at making sure that we don't lead to confusion and recommendations. So this is something with a living guideline that we have the ability to do, to update things when messaging comes down or the evidence changes. Those are the main things I wanted to highlight. Next slide, please. And that's from there, I'm going to move on to handing it over to others, and happy to take questions now or at the end of the session. Thank you.
Okay, thank you so much to Dr. Marshall as well as Judy for that wealth of information. What we're going to do now is just get into part 2 of our session today, and that's going to be talking about the athletic therapy role at the front line of concussion care. So this is going to be from the point of injury right through to return to play. So for this, we're going to have Drew present 3 different case studies to us, and he's going to go over these cases. He's the chair of our concussion working group, and at this point, Drew, I'm going to hand things over to you.
Can everybody hear me? Thank you. So one thing before we begin, I want everybody to take your fingertips. I want you to bury your fingers fairly forcibly into the suboccipital area where you would traditionally do a suboccipital release. And then once you've got your fingers there, I want you to look as hard as you can with your eyes to the left and to the right. Don't move your head, but just move your head to the left and to the right. I'm just gonna check. Okay, I have a camera, but it doesn't seem to be working. But the basic premise that I just demonstrated to you was a baseline of what we go with, and that is using muscle energy to correct the energy, to correct some very specific lesions that we're finding. So from case one, we can see that we had a 32-year-old amateur hockey player. She had had numerous concussions previously, and she was basically on a breakaway. She was pushed, and she slid into the boards, and then one of the opposing players decided to make sure that she stayed down, and she came up and cross-checked her on the back of the head and of the neck. What this did for this poor woman is it instantly created a severe headache that really did not abate. Now, when I was able to see this woman, she was at the she was into 4 years of constant headache, and she was not able to work. She was actually had to go off work because of the bass drum that was beating in her head. She was not able to work. So she was very, very despondent. She loved her job. She was an investigator. So that was a very great change to her whole life. When we came to look at what was going on, one thing that we focus in on first is what's going on with the neck. So when we worked on her, or when we examined her neck, her range of motions didn't look too bad. But what on palpation, we could definitely feel some of the muscles, specifically the deep neck flexors, were extremely rigid and painful to digital pressure. And there's a little technique that we've started to develop where we look at the actual movement of the C1 and C2 joints as it's related to the occiput. What we're finding in these concussions, especially if they have symptoms longer than 7 days, that this lesion is present in all of these people. Now, to fix that, we use that little reflex that you felt when you dug your fingers in there. So we were able to use that, the reflex contraction of the suboccipital muscles to actually pull the C1 back into its position. The other thing, so once we corrected C1 and worked on some of the musculature in the area, she felt noticeably better. She got up off the table and said she knew something had changed right away. She still was symptomatic. As we continued to delve into her condition, then we really took a close look at what was going on with her eyes. So we found that in terms of dealing with doing some very simple saccade work and evaluating how her eyes were moving, we made an immediate referral to an optometrist that has had a lot of specific training in dealing with concussion assessment as related to optometry. It was found that there was several things that were going on. She was prescribed some prism glasses to help correct some of the vision stuff, where she noticed once again significant improvement right away, but she was still having problems. The optometrist, and we give her great credit for this, she felt that she saw something on the retinal scan that they did at their clinic. There was a referral to a neuro-ophthalmologist who did a more in-depth look at her retina. And the very amazing thing is that once he got the results, he was able to go and speak to the patient, said, you know, from your retinal scan, I can tell you've had at least 4 severe concussions. And and he was able to identify some specific lesions to her retina. They ended up doing laser therapy, which cured about 95% of the retinal issues, and she was able basically to return back to normal life. She's back working. She's back playing hockey to a little bit. She still has issues with her vision from time to time, but she's on an ongoing vision correction exercise program, and she's doing very, very, very well. So that's and that was a very rewarding case to work with, because she was such a hot mess when she came in. We're able to this weekend we were exposed to some information where a full 50% of people that commit suicide post-concussion have visited a physician within 2 weeks of their suicide. So we're dealing with some very important information that we need to be aware of. We need to treat each person with the urgency and with the care that is required of any person. But we have to realize that these people have had brain injury, and there is the potential for greater effects down the road. Okay, case number 2 was a male hockey player, semi-pro, had numerous concussions. By the time he came to me, he was out of hockey. He just he was in constant headache, constant neck pain, and he was not able to he was barely able to function at work. He kept complaining that he had this great amount of fog that he was dealing with, and he was actually starting to have issues with anxiety. The more that his symptoms wouldn't go away, he was becoming more and more anxious. So this is another a case of somebody that, you know, was having dramatic effects of post-concussion syndrome. On assessment, as always, we did a SCAT-5. We checked for the C1, C2 hypomobility, and not shockingly, we found that it was very severely locked. There was also quite significant tenderness at C3 and 4. And it was interesting, the patient actually described that he felt like he was stuck, and that he was twisted. And that was how he came to describe things. So as we continue on, we actually went through our SACOD assessment as well, vision assessment. There was enough there that triggered us to refer him on to our referral source. In the meantime, we did all of our good athletic therapy stuff of continuing to treat the cervical muscles, working on the deep neck flexors, and increasing their flexibility and their strength. He was prescribed tinted glasses, once again with prisms, to help correct the visual impairments that were found. With his concussion fall, as we were able to sort of break through those symptoms, we were actually able to go into like our regular concussion return to sport activity with bringing his exercise level up, slowly introducing weights, increasing his screen time. So it was very rewarding as to we could just take this severe concussion and plug them into, you know, our regular return to sport activity and protocol, and he's now back playing hockey. He was working full-time as a financial advisor. We see him, you know, every so often. Hockey players tend to fall on their butts. So whenever he falls, his anxiety kicks in a little bit. So we get a phone call the next day, and we just go through and correct it, anything that needs to be corrected, or we hold his hand and let him know that everything's going to be fine, which is another big component of what we do in athletic therapy, is that support, the mental support of our athletes. And that's great. The third case, this is a funny, not so funny, because she is another, she was a rugby player, 14-year-old, was playing rugby, got tackled, hit the ground fairly hard, and through the course of that tackle, she was kicked in the head. Play continued. She was tackled again, and then when they established a ruck, as the ruck went over her, she was kicked in the head once again. So two blows to her, well, three if you count hitting her head on the ground, plus the 2 kicks to her head. She was taken to the hospital for screening, and then about a week later, well, actually it was 2 weeks later, when they found their way to our clinic. Once again, we administered the SCAT-5. She exhibited, you know, 16 of 22 symptoms, which, you know, isn't, you know, so shocking to many of us that deal with the concussions. She had high sensitivity to noise and to light sensitivity. She was very, felt like she was in a very, like in a fog bank, and she was having great cognitive challenge. There, as you can see, that her memory scores weren't too bad, and the concentration, 3 out of 5, which would be enough for us to have concerns. Her balance was quite off, and even her delayed recall wasn't too bad at 4 out of 5. I think now with the new SCAT-6, we are seeing with the 10 item recall, we are going to see significant changes in that, especially in the delete recall. One other thing that was playing a part of this, she had significant forward head posture and forward shoulders. And as you're taught in school, we try to make our patients better than they were before they got hurt. So that was one thing that, as well as working with her concussion symptoms, is that we're also working very hard on correcting her posture, and giving her reasons, and explaining the rationale for that and how it all plugged into a big component of getting her concussions better. Once again, we found that the deep neck flexors were a real mess. Treated them with the trigger points, and did, you know, a bunch of myofascial release. The very important thing for her was working on her posture and her neck exercises. So just with the cervical correction and correcting a lot of the neck issues, her symptoms were down by probably 50%. She was still, by our standards, she was still significantly affected, and we made and after SACAD evaluation and our visual evaluations, once again, she was referred. The optometrist was able to find some significant issues going on with her eyes. She was prescribed glasses with prisms. And the amazing thing was that within 2 days of having her prescription and receiving her glasses, all of her headaches were gone, and all of her fatigue and the fog went away. It was quite remarkable. That was the first case where we've seen, that rapid of a correction of that. So that was an interesting outcome, and we were happy to help this young girl get back to school. That is the my little presentation. So I think we have some other great material being brought forward, and I'd turn things back over to Tyson.
Thanks so much, Drew, for going over those case studies with us. And thanks to UNH as well for inserting those important references and guidelines. One thing that I wanted to touch on as Athletic Therapy Ontario launches Concussion Week with this terrific educational webinar. We know that midweek, the final Wednesday of September, so this year it's September 27th, we will stop to pay tribute to Rowan Stringer and the province of Ontario's undisputed leadership in concussion care. Ontario is the only province in Canada with legislation like Rowan's Law. So for those of you who may not be familiar with Rowan's Law, it happened when there was a 17-year-old Ottawa area female rugby player whose name is Rowan Stringer, died in May of 2013 while playing her beloved sport, which happened to be rugby. Her tragic death resulted in unprecedented advocacy and a call to action led jointly by MPP Lisa MacLeod and Rowan's dad, Gordon. And OATA recalls being there as one of the first healthcare professions standing with these two champions. We were there at the coroner's inquest when the 3 words, second impact syndrome, were stated. And we were pleased when the coroner's independent review and recommendations included the important role for athletic therapists. This is recommendation 38 for ATs to be present at every practice and game as frontline concussion care experts. We as athletic therapists take this role and duty seriously. This is why we start this week with the benefits of the experts who are sharing their network of concussion treatment and diagnostic content to keep us practicing at the top of the concussion management game. So before we wrap things up and head to the Q&A session, I just want to go over some key takeaways with you guys today that were brought forth in the first and second segments. So first of all, there are evidence-based care pathways and living clinical practice guidelines that are easily accessible and available for us to use. We are going to provide the links and QR codes to those guidelines. And of course, they will be available on our website as well as the portal as well. Second, the importance of timely and comprehensive individualized assessment with validated evidence-based tools. And third, the value of providing education to patients as well as their families to dispel any misconceptions about symptom management, treatment, and prognosis. And then finally, team-based care with clear pathways of evaluating the effectiveness of treatment. So those QR codes will be available and to anyone who would like to download them. And they will be available on our website and portal as well as mentioned. So at this point in time, I would like to welcome any questions that anyone may have regarding our presentation today.
Am I allowed to ask a question?
You are, Judith. Over to you.
Dr. Marshall, I was just wondering if you could speak to what happens when sort of new technologies maybe come into the business end of things and how that ends up getting reviewed and finds its way into the guideline.
That's a great question, Judy, because I think that all of us are looking for best evidence, and I think there's some need to evaluate things. So I think that when we look at new technologies that are rising. I think biomarkers are a good example of that. We look at the literatures associated with them, and I think we're looking at kind of what can be helpful in both diagnosing and treating concussion. I think our job is to do a balance of looking for evidence, and I think that evidence is through trials and examination. There are some technologies that are purported to be effective at treating concussion, which do not have the evidence to support that. And in fact, there are harms. There can be harms of technologies, patients using them, unintended harms or consequences, financial consequences, direct harm of interfering with expectation, or harm of delaying care of known treatments that are more effective. So I think that I always, worry about that, but we look at incorporating that evidence. We also, if the evidence isn't strong enough to make a guideline recommendation, we also will put that in our guideline as to, emerging potential treatments. But I think there's a lot. It's a really good, relevant question now, because in the future, while we're used to, therapy interventions, pharmacological interventions, certainly interventions such as neuromodulation, there is emerging evidence that these interventions will be effective for managing concussion, just like some of the interventions we were talking about today that were presented that were effective. So I think it's really about all of us working together, making sure we have the best information for patients and the best treatments. Thanks.
The other thing I just wanted to mention is that on that concussionsontario.org website, there are resources that you can download and actually give to patients and families. There's a quick tip on do's and don'ts for patients and families, and there's some other resources there as well. So it's not just resources that you can use clinically. There are things that you can download for patients and families. The same is also true for the other living guideline websites.
Well, if everyone's shy or so knowledgeable, there are no additional questions. Tyson, would you like to thank everyone and just remind them where they'll be able to get the PDF of this fabulous content and all the resources that Judith and Dr. Marshall have shared?
Absolutely. I just want to give a big thank you to everyone who participated today, Judy and Dr. Marshall and everyone with UNH and all of the partners who provided all that wealth of information for us. Drew, thank you so much for stepping in and helping me out with these case studies that you presented to us. And again, all of this information, as well as the presentation, will be made available rather, on our website as well as in the portal. Just thank you to everyone for attending today.
Thank you, everyone.
Thank you.
Thanks very much. Bye-bye.
For having me.
Happy Concussion Week.
I don't know what happened to my computer or to my camera.
These things happen, Drew. What can I say? When you least expect it, that's when it happens. But I think it turned out okay.
Well, I have a face for radio, so it's probably better that it was just my voice. So,
well, no, I think it worked out well. Anyway, Parwana and I are going to sign off now. Thanks, everybody. Thank you.
okay.
Bye-bye.
Thank you.